Jake is a lively young man with severe intellectual disability and autism. He loves water and has a range of sensory-seeking behaviors and sensory sensitivities. Jake has displayed hyperactivity, severe sleep disturbance and agitation, with food-seeking, aggressive and destructive behaviors since early childhood. His dedicated family made huge changes to the home environment to reduce sensory overstimulation and risk, for example, locking food cupboards, keeping blinds closed and removing taps when not in use. Jake presented to psychiatry already on aripiprazole and clonidine for these problems. A detailed history revealed unrecognized severe constipation and overflow diarrhea. Jake would have been unable to manage in a hospital setting, so his family supported a disimpaction regime at home. He subsequently passed the whole banana skin including the stalk, leading to a significant improvement in well-being and behavior. However, it took many months for Jake to regain continence, greatly increasing his care needs. Jake's Pica had previously been unrecognized. He was secretive when eating non-food items and he had used the toilet relatively independently. His incontinence revealed that a wide variety of items had been eaten, including stones, plastic seals from pipes, parts of headrests and mattress covers, foam from mattresses, and rubber/wooden door stoppers. This was despite a high level of observation and vigilance of family and carers. Consideration was given to scans to see whether there were items still in his gut, but it was not thought that the general anesthetic required would be justified, as it would have been unlikely to alter his management unless presenting with symptoms of an acute abdomen. He was treated empirically for H. pylori. Jake often ate items with silicone or rubbery textures, and attempts were made to meet this apparent sensory need in safer ways. Chulery, that is jewelry designed to be chewed by those who experience oral hyposensitivity, was unsuccessful as this is designed for small children and Jake was able to bite right through it. Dog chews were tried instead, but he did not accept them. Family, school and respite carers primarily managed Jake's Pica through close observation and offering him edible items when he was seeking non-food items. This was not entirely successful owing to his drive and secrecy around Pica. Careful bowel monitoring and management of constipation and abdominal pain helped reduce agitated and aggressive behaviors, although these remained intermittently severe in association with abdominal pain. It was recognized that Jake's psychotropic medication may have contributed to his constipation. Improvements in agitation made it possible to wean Jake off aripiprazole, but he continued to require clonidine for hyperactivity and sleep disturbance. Jake subsequently cracked a tooth, probably secondary to eating stones, and required a general anesthetic to allow dental treatment. The induction process was extremely difficult, and despite significant amounts of sedation, restraint by multiple staff members was required. The state of Jake's teeth meant that total dental clearance was required. Following this, Jake was able to eat food well, and there was a dramatic and sustained reduction in Pica. Jake's Pica may have contributed to the dental problems, but the Pica may have escalated as he then used it to attempt to soothe his dental pain. Unfortunately, the Pica subsequently gradually increased again, and ongoing close supervision and monitoring is required.
This case study of Jake is from Williams and colleagues, which gives you a snapshot of how Pica can take over your life, both as the person who was affected by Pica and for their caretakers. So, what is Pica and what is its clinical relevance in therapy? Pica is a feeding and eating disorder that is diagnosable for individuals over the age of 2. The common theme and problem for researchers is very few epidemiological studies of Pica exist, which investigators argue is due to Pica being underidentified, underreported in medical and clinical records, and therefore undertreated by clinicians. The research that does exist are usually case studies, which have limited external validity. Pica is usually only discovered in an individual following medical complications like a bowel obstruction, intestinal perforation, and even poisoning. There have been no specific biological abnormalities associated with Pica, but that could be, again, due to limited research and data. Further problems for clinicians and researchers who seek the underlying cause of Pica is its high comorbidity rate with mental and developmental disorders such as autism spectrum disorder, intellectual developmental disorder, and in some cases, schizophrenia and obsessive compulsive disorder. This might make it impossible to isolate the single cause of Pica in the individual. Some important factors researchers must consider when conducting studies is to rule out vitamin or mineral deficiencies as the cause of Pica. So other things like food insecurity due to environmental or socioeconomic factors, another feeding and eating disorder like anorexia nervosa, where the individual may ingest non-nutritive substances like tissue or cotton for the purpose of controlling their appetite, cultural practices such as geophagy, or the eating of earth and clay, that is common in some countries in Africa and other parts of the world. Neuroimaging seems to suggest that individuals with Pica all had a lesion in the posterior part of the middle temporal gyrus, which is related to semantic memory deficits and lead to difficulties recognizing objects. But researchers must always need to distinguish between correlation and causation. Since there are so few studies on Pica, researchers cannot definitively state that every case of Pica showed the lesions, since not every case of Pica is reported. Basically, at this point of Pica research, the data is not robust enough for generalizability, and therefore treatment and recommendations must be given and received with caution. The first study is by Ahmed and colleagues, whose research focused on the prevalence of Pica among adolescents in northern Sudan. They ran their study from July to September among nearly 400 students between the ages of 10 and 19. The students were randomly selected and comprised of roughly a 50-50 mix of male to female students. The data was collected via interviews conducted by trained medical officers comprised of 2 males and 2 females. The education level of the parents were also considered. Their analysis showed a rate of 30.7% prevalence of Pica among females whose father has a lower level of education, specifically for geophagia and pagophagia, which is the eating of ice. My analysis for Ahmed and colleagues' paper is it met its goals of researching the prevalence of Pica among adolescents in northern Sudan for the purpose of educating caregivers, other researchers, and health planners on the severity of the issue. However, its clinical usability and generalizability to the Pica population around the world will be low because geophagy reflects religious beliefs and cultural practices in Sudan. The article does not indicate whether the students were asked why they consumed clay and sand, just if they do. This means the etiology of the students' Pica remains unknown. The article does not cover treatment or intervention for Pica and does not mention physiological causes other than speculations of high level of anemia and trace element deficiency. A reflection that came up for me was if the females whose fathers have a lower level of education may also tend to answer a certain way to the medical officers, causing the results to be skewed in that direction. The second study, by Moline and colleagues, is a case study done right here in Vancouver, BC. The subject is Olivia, a 10-year-old white girl who lives with XXX syndrome, ASD, ADHD, and has a trauma history. In this article, there is no attempt to explore the etiology of Olivia's Pica. The focus here is to implement their empirically supported modular transdiagnostic treatment called MATCH-ADTC, or Modular Approach to Therapy for Children with Anxiety, Depression, Trauma, or Conduct Problems. Over the course of 26 sessions, Olivia's Pica was significantly improved, and at the 6-month follow-up, the Pica behaviors were nearly gone. Moline and colleagues' article provides a useful framework for understanding Olivia's intricate case, which involves multiple contributing factors to her Pica, such as trauma, attachment dysfunction, ASD considerations, and learned behaviors. The treatment, conducted over 26 sessions across a year without medication, heavily relied on the entire family's consistent engagement both in sessions and at home. Prior to the MATCH-ADTC program, Olivia's parents reported providing near constant supervision in an attempt to control her Pica behaviors. However, this may have proven ineffective due to the absence of a clear, structured approach. This raises an important question regarding the efficacy of the MATCH-ADTC program. Was the progress due to its training on Olivia or her caretakers? Also, Olivia was reluctant to talk about her Pica behaviors at first, which made her resistant to treatment, but as the program progressed and her family got more involved, she became an active collaborative participant in the program. This shift suggests that openly addressing Pica within Olivia's family environment may have significantly reduced the associated shame and stigma, fostering her engagement and contributing to the sustained decline in her Pica behaviors. Furthermore, a critical methodological point is the potential for bias in the data, given that Olivia's parents were responsible for recording and reporting the Pica behaviors, which could compromise the consistency and accuracy of the results. The third article by Van Vert and colleagues is a case study that focuses on Vera, a 30-year-old highly educated single black woman living in the United States who self-reported her Pica behaviors of foam rubber and burnt match heads known as cotopyrophagia. This article is unique because there has been very little research on Pica individuals with no intellectual disabilities. Vera does, however, live with comorbid depression, anxiety, and obsessive-compulsive symptoms. Vera's treatment consisted of CBT, DBT, and psychopharmacology, which took place at the outpatient clinic 3 hours a day, 5 days a week for 14 weeks. The treatment was extensive, thorough, and involved a large team. Vera's Pica consumption was verbally assessed at each counseling session. Medications included a daily dose of escitalopram and clonazepam, but was found to be ineffective. Vera eventually found sertraline and risperidone to be effective, but it is unclear if or when Vera will continue with the medication. At the end of the 14 weeks, Vera reported her Pica behaviors had ceased, and additionally reporting an improved sense of self-worth, mood, self-efficacy, emotion regulation, but most importantly, a new sense of hope. What makes Vera's case particularly clinically useful is her ability to fully verbalize her Pica experience, including its origins and perpetuating factors. This contrasts sharply with most Pica studies since we now have a subject with the ability to articulate her Pica's cause and maintenance, which significantly broadens our understanding of the comorbidity that frequently accompanies this disorder. The author found that Vera's Pica was a manifestation of emotional dysregulation, persisting due to its self-soothing properties, including the comforting taste of foam and its ability to calm her during moments of distress and boredom. In her treatment, Vera explores her underlying emotional and physiological needs for her Pica behavior, which helps identify her motivators for change. Van Voort and colleagues do admit, though, it was helpful to share a glimpse of Vera's world of Pica, which provided some insight behind its emotional and physiological components. It is still complicated in that the precise etiology of Pica is still unclear. Treatment was provided to Vera's Pica as well as her comorbid disorders, which means specific effective treatment for Pica remains unknown. Since this is an outpatient program and Vera's behaviors were all self-reported, we must always question its accuracy and consistency. Additionally, this program, being thorough and intense, may only be effective for other well-educated and highly functional individuals like Vera, and not for someone who make up most of the Pica population, which is a person who lives with an intellectual disability. The last paper by Williams and colleagues acts more like a guidance for clinicians to assess and manage persons with Pica, and I've included this for interest and information. The epidemiology of Pica in 2 to 3 year olds with autism is 23.2%, and with intellectual disability is 9.7%, compared with 3.5% of controls. The authors list the physical and neurobiological conditions, the mental and developmental disorders, the social and environmental factors, and complications that may be associated with Pica. Then the behavioral and physical interventions with Pica is listed down here, which I've covered already. The authors even list a flowchart for the recommended treatment of a child with Pica, but it is by no means a standardized treatment. One table that might be of interest is table 1 here, and it is the pharmacological treatments that have been reported in Pica literature, but note that most of them are quite dated. Pica is a highly heterogeneous disorder, making broad generalizations challenging. Therefore, the traditional pursuit of high external validity in Pica research aimed at treating an entire population may be less applicable. Given the unique presentation of each Pica case, a single subject research design, where each individual effectively serves as their own control, often proves more appropriate. This approach emphasizes the individualized treatment tailored to the person in front of you, rather than a one-size-fits-all solution. However, this individualized focus inherently limits the generalizability of findings and presents significant challenges for rigorous research. Specifically, case studies, while providing rich, in-depth data, are particularly susceptible to researcher and reporter bias, which can compromise the objectivity and reproducibility of results. My reflections suggest Pica is more prevalent than acknowledged, especially outside the intellectually disabled population. Its largely hidden nature stems from the pervasive stigma, shame, and guilt it evokes in many cultures, compelling individuals to conceal their behaviors. This means cases often emerge only through self-report, skewing perceived prevalence. Secondly, we cannot overlook another crucial aspect of clinical relevance in therapy, and that is the profound caregiver fatigue experienced by those supporting someone with Pica. The relentless daily challenges, emotional hardships, and immense stress they face truly warrant dedicated research and observation. These caregivers are often silently struggling and will undoubtedly require therapeutic support themselves. The challenge then becomes this: how can we encourage disclosure and generate sufficient interest to secure research funding for Pica? Greater openness about the disorder is crucial for sparking broader awareness and investment, increasing interest and support. Thank you for taking the time to watch my video, and I hope you enjoyed it. Aspect of clinical prevalence. Oh my dose of acetalo acetal sertraline and colleagues regarding the efficacy of the regarding the efficacy match ADTC